much as what been told by Dr. Patrick, but we're going through practical issues about treatment of heart failure. And then we're going to go through about SGLT2i inhibitor evidence in treatment of heart failure reduced ejection fraction. This is my disclaimer. Right, so I always find treatment or managing patient with heart failure is always a difficult battle because of the complexity of the disease itself. Okay, we've got lots of weapon with us. We've got ARNI, we have beta blocker, we have ACE inhibitor, we have spironolactone, but still you can see here, despite the availability of therapies, 5 years mortalities remain high. I don't want to go through the HFrEF, preserved ejection fraction, but because that's even more complicated, because at this point, there's no option in terms of treatment in the guideline. Right, so if you look at this graph here, so we've been using ACE, beta blocker, MRA, and ARNI, but despite that, you can see there's still residual risk, which means there's still room of improvement in terms of treatment for HFrEF. So these are the practical issues that I think all of us who's treating heart failure in our day-to-day clinical works has been facing. Titration of the medication, the side effect, patient being hypotension, as well as bradycardia. As you can see from the table here, most of our heart failure medication, they don't come with a single dose tablets, okay? Often we have to titrate the medication to the tolerating dose for the patient. And SGLT2, the good thing about SGLT2 is a single dose and doesn't require titration at all. We look back at the Asian HF study. For here, we can see the overall uptake of ACE inhibitor and ARB is about 77% in Asian countries, but only 17% achieve guideline-directed doses. Same goes for beta blocker. Not too bad, 79% of the countries, started patient with HFrEF on beta blocker, but there's only 13% achieve guideline-directed doses, which means there's difficulties in titrating the dosage up to the targeted dose. The next thing that we worried about is kidney function. Not just us, even the patient themselves. They always are, oh, they're not going to take this medication because it might affect the kidney. How does it work? I mean, how does heart failure cause kidney failure? I think it's been mentioned by Dr. Rizmi earlier from the first session. Reduce cardiac output, reduce hypoperfusion to the kidney, and it can cause GFR declination and tubular cell toxicity. But it's a vice versa. So you can see patient with eGFR less than 60, the rates of heart failure is about 3 times higher compared to those above 60. And you can see here from the graph, the blue line here is the rate of declination of eGFR as we grow older. But once patient develop heart failure, the slope becomes even steeper. Okay, they reach worsening of the kidney disease even earlier. And despite starting RAS inhibitor here, you can see a graph on the right, it doesn't really help in terms of slowing down the slope. Okay. The next issues is, of course, the side effect of hypotension, electrolyte imbalance, being bradycardia, dry cough, which we see in ACE inhibitor, as well as angioedema. And to start beta blocker, sometimes we kind of worried because patient who has asthma might, predispose patient to exacerbation. Erectile dysfunction, we often seen them in our clinic. Patient with angioedema, those on ACE inhibitor and ARNI, as well as gynecomastia in patient on spironolactone. So there's a lot of issue. There's a lot of, even though we've got option of treatment, so there's room for improvement. That's why I think SGLT2 inhibitor come in terms of, treatment for heart failure. So the story of SGLT2 inhibitor in heart failure started a couple of years ago. It started off by looking at heart failure prevention seen in Canvas study, DECLARE, EMPA-REG. And at the moment, there's ongoing study looking at SGLT2 inhibitor in patient acutely decompensation heart failure or patient with MI. And to the extreme, patients who establish heart failure. And initially they look at type 2 diabetes only, but now they also look at diabetes and non-diabetic patients. Sorry. So just go back to the slides. Right, so these are the cardiovascular outcome trials that have been shown earlier. Just to share again with you guys, the HFrEF, Canvas, Declare, and Vertis studies has showed significant improvement in terms of hospitalization of heart failure. And for the CV deaths, there's only HFrEF that showed significant benefit for the prevention of CV deaths. So these are the mechanisms that are being proposed on how SGLT2 inhibitor benefit patients with heart failure. So it start off with increase in natural resist, improving the kidney function and cardiorenal physiology, reduction in interstitial edema, as well as reduction of LV wall stress. So last year, 2019 ESC, we've been introduced by one of the studies called HFrEF, looking at dapagliflozin in reducing worsening of heart failure, CV death in patients with HFrEF, whether they have diabetes or non-diabetes. And the primary outcome showed significant results of its reducing heart failure and CV deaths, as well as total hospitalization in heart failure, as well as improvement in symptom score and quality of life. All right, now let's go through the latest study with regard to SGLT2 inhibitor in heart failure reduced ejection fraction, which was introduced during ESC Congress 2020, the EMPEROR Reduce study. So the study was designed almost similar to DAPA-HF study. So patients class 2 and 4 chronic heart failure, ejection fraction less than 40%, with evidence of elevated NT-proBNP, regardless whether they have diabetes or not, and they have to be on the standard care of heart failure medication. Then the patient was randomized to those who's taking once daily empagliflozin and once daily placebo. And patient was followed up for about 16 months. And looking at the inclusion criteria is almost the same for both, but in EMPEROR Reduce, they are a bit meticulous with regard to the NT-proBNP. So different set of ejection fraction will require different set of NT-proBNP level. And you can see here, with regard to exclusion criteria, EGFR less than 20 was excluded in EMPEROR, whereas in DAPA, they exclude those less than 30. Let's have a look on the baseline character of EMPEROR and DAPA. So you can see here, ejection fraction is slightly lower in EMPEROR, about 27, and 31 in DAPA-HF. Patient EMPEROR has higher value of NT-proBNP, and can see here EGFR as well on the lower side, about 60 compared to DAPA, about 66. And you can see patient with under EMPEROR study, they most of them already on, not most, but they more patient on ARNI, ICD, and CRTD compared to DAPA-HF. So these are the endpoints for the EMPEROR Reduce study. We're going to look at the adjusted CV deaths or heart failure hospitalization, recurrent heart failure hospitalization, as well as the kidney. So this graph has shown significant benefit in those on empagliflozin group. You can see the separation early and it's maintained separation towards the end of the studies. Here we can say the absolute rate reduction of 5.2% with regard to preventing CV deaths and hospitalization and heart failure on those taking empagliflozin. And the number need to treat here is, I would say, excellent. It's 19, which means there's only required 19 patients to be on empagliflozin to prevent one CV death or one hospitalization of heart failure. So if you look at here, if you look back for those diabetes and non-diabetes, there's not much difference. Both groups favor empagliflozin. Yeah? And some people might ask whether this patient should be on ARNI first or we can start the SGLT2i inhibitor before the ARNI or after ARNI been given. Looking here, there's not much different. Both group favor SGLT1 inhibitor, SGLT2 inhibitor, sorry. So that's a tick there. Now we're looking at the total hospitalization for heart failure. Clearly from this graph, you can see early separation as well and the maintain of the separation towards the end of the study and the relative risk reduction of about 30%, okay, which is quite good. And the next thing that we worry about is when starting a treatment, whether it's gonna make the kidney worse, or in this case, we want to prove to, they want to prove to clinicians that SGLT2 inhibitor can actually protect the kidney. There's always the initial dip when starting patient with SGLT2 inhibitor, as you guys know, but you can see here the empagliflozin graph kind of horizontal. It doesn't really slope down compared to the placebo, which, you know, even steep sloping down. And once the empagliflozin has been stopped, you can see there's increase or improvement of the eGFR. So here it shows the risk, the rate of reduction of eGFR for those on empagliflozin is about 0.5 per year, whereas those on placebo, the reduction rate is about 2, okay? So it's kind of protecting the kidney and preventing it from getting worse. So one of the things that we look at as well in the study is whether this medication actually improve quality of life. So they use the KCCQ-CSS questionnaire to assess patients' quality of life. And here it showed significantly improvement in terms of quality of life on those on empagliflozin. And with regard to the safety, you can see here there's no difference between the groups with regard to the hypotension, hypovolemia, hypoglycemia, as well as the ketoacidosis. There's none case being reported of ketoacidosis in this study. So if you look at these primary endpoint results of the modern trials that have been mentioned by me earlier, the HFrEF, as well as Dr. Patrick earlier on with regard to Paradigm and Victoria study, you can see all of them showed very good number need to treat, 19, 21, 21, and 36. So all of this actually might have improved the outcome patient with heart failure, reduced ejection fraction if we use it. Okay, same slides that showed by Dr. Patrick earlier on. So important treatment goal in patient with heart failure is not always preventing the disease progression, but we need to improve patient health status as well. There's no point prolonging their life if their quality of life is bad. And here you can see the different medication show different effect on the pathway. The SGLT2 inhibitor tick for all 4 pathways, and it can compensate the other medications. And here again, same slides that you've seen earlier on. So we have diuretics as a symptomatic treatment. And here we have ARNI, ACE, MRA, and beta blocker as our current medication for HFrEF in the guideline. But bear in mind, SGLT2 inhibitor is not yet in the guideline, but I think it has a great potential to be initiated in patients with HFrEF in terms of improving patients' outcome. With that, thank you very much for listening.